the subject I'm going to speak about, there aren't any active UK companies at the moment. They all backed off in terms of the articular cartilage work because NICE spent 4 years procrastinating over a decision about whether or not we should be doing it. We'll come to that in the end. None of the rest of them are relevant. So Professor Smiley was the Professor of Orthopaedics in Dundee where I trained. He was there in the 50s and popularised total meniscectomy. He believed, and he really did believe, that when you took the whole thing out using these Smiley knives, that a regenerate would form invariably. Unfortunately, that isn't true, as we all know. So total meniscectomy does have long-term consequences, and the consequences are shown the longer the study follows patients up for, the higher the rate of osteoarthritic change. And that's not just on an X-ray. So Yanis Pengas was my knee fellow, he's now a consultant down in Truro. For his MD, he followed these patients up in a prospective study that was 40 years long and found that there was a massive increase in the rate of knee replacement 40 years after a meniscectomy, 132 times more likely. So if you can, we should leave as much of the meniscus in as possible. So surely taking out a little bit of the meniscus isn't as bad as taking out the whole of the meniscus, and that's true, but not always. So it depends upon the type of meniscectomy you do. And if you do a small amount of meniscal trimming, but you go out to the periphery, then in effect, although there's still 95% of the meniscus there, you've defunctioned it, and functionally it's the same as carrying out a total meniscectomy. And the stresses that the articular cartilage face are just as bad. So when you're faced with a meniscal tear that is repairable, then I would beg you to repair it, even though it's a bit fiddly. Fast fix is my preferred method. Inside out can be done. I'll show you a couple of the techniques as we go along. There's many different ways of classifying it. You can look at the zones of involvement, as we do in the National Ligament Registry data, or you can talk about it in terms of its morphology. And there's a number of different techniques for repair, and the kind of darts and things seem to have passed out of favour now. There's a couple of guys still using them, but they were so stiff, although they were easy to use, they were causing damage and have really sort of dropped off the market, I think, in the UK anyway. So the forces the meniscus face are absolutely massive, and repetitive loading 1-2 million times a year, even in sedentary individuals, are going to mean that at the end of the day, even though the thing is designed really well by nature, and EM studies confirm that the diagrams that Aronsky showed us and Dodds are accurate, that they are going to tear. The good news is that the outer third in adults, and even more in younger patients, has a blood supply. And so when there's a blood supply, there's something that we can play with to try and get it to heal. It'd be nice for it not to happen in the first place. And the things that can be prevented are ACL injury, so the 11 plus FIFA rehab or prehab sort of techniques, where a lot of professional clubs and many amateur clubs now are getting the kids to do certain exercises as part of their warm-up. Do that 2 or 3 times a week, then you will significantly reduce the rate of ACL injury and subsequent meniscal tear. And we can prevent arthritis. We can reduce its rate if you carry out a successful meniscal repair. And over in Liverpool, myself and some colleagues set up a preventative program that was used in schools and some of the local clubs, and did identify a reduction in injury rate. So it's much better to stop it happening in the first place. But if it does tear and then you go on to require an ACL reconstruction, then if there's a repairable meniscal tear in there, then it's really important to repair it, because you will significantly reduce the risk of arthritis for that patient over the next 10 years or so. So is meniscal repair a new thing? Not really. This is the most interesting paper I've ever seen in the British Medical Journal from 1885, I think it was. And the Professor of General Surgery in Edinburgh at the time, Annandale, carried out an open meniscal repair successfully to address the problem of a locked knee in a minor. Unfortunately, he didn't have antibiotics and he died of sepsis a while later. But his meniscal repair saw him out. So if we think about what we're going to do for meniscal repair, then we need to think about the age of the patient. And that could be a number on his birthday card, or it could be a biological age. So if you want young, fit people, it can't have been there for too long, but at the end of the day, I've seen tears that have been a problem for several years that have been repairable, and I've seen others that have been there for a couple of weeks that are just knackered because of plastic deformity. The site's important. So some of the zealots, as I'll show you later, would have you believe that you should be repairing white on white tears. Personally, I don't think that's right. So red on red or red on white tears. And then if there are associated injuries, they should be addressed. The success rate of meniscal repair in an unstable knee is about 60%. If you stabilise the knee, it's up to 90%. And then, again, the tissue quality is important. So if it's knackered, chop it out. You can get anything to heal, but if it looks like it's degenerate, then it's probably better to remove it. But should we operate at all? I know that lots of people from Sweden and America are trying to stop knee surgeons being able to earn a living, but actually sometimes you don't need to repair or trim a meniscal tear. And so this study carried out some time ago now looked at what you should do, or how you could assess a meniscal tear to see whether you should do anything to it at all. So if it's stable, if it doesn't move more than 3 millimeters when you tug at it, you don't need to do anything about it. A radial tear that's less than a third of the diameter of the meniscus should be left alone. And don't mess around with them. You can always pull it hard enough to turn it into something that you need to do something to. And does that work? Well, Gilchrist and De Haven looked at their patients, and out of a massive series, they found a small number of patients, so it's not a common thing, but it's there, 80 tears, and when they followed them up by a 4-year follow-up, between 2 and 10 years, they found that there were only 6 failures, and only 2 of those were because of persistent problems, and at that short follow-up, no development arthritis. So, as I said before, if the tissue's knackered, don't stitch it back in. If it's a small tear, you should leave it alone. If it's in the middle third and it's got a wide rim, you probably don't need to do anything about it. If you can't get the thing to sit back down again, then it's not going to stay with a couple of bits of string, no matter which manufacturer has made that. And then you need to think about the patient's occupation. If you do a meniscal repair, and you're going to ask them to not crouch for 3 months to protect the repair, then you might put somebody out of a job, you might put somebody's house at risk, and if you've not consented them for it, you might be in trouble. Athletes look after a number of kids from academies, and it's always a difficult conversation with the parents. They've got the next little Rooney there, and they want them back in training in a fortnight. I'd like them to be able to walk when they're in their 40s. So personally, I'd argue very strongly for repairing menisci where it's appropriate, but at the end of the day, we're the patient's servant, not their boss. And then in older sedentary patients, it's not worth bothering. And older, unfortunately, isn't that old, as far as I'm concerned anymore. And there are a number of papers looking at what happens if you try and repair patients over the age of 40. And that seems to be the kind of cut-off in the literature. But as I said, biologically is more important than chronologically. So do we have to go back in again? Even with meniscal trimming, there is a reoperation rate. It's 2% in my series, from this paper 4%, but it's a much higher rate if you repair the meniscus. So in my own hands, with about 5 to 7 years follow-up, it was 10%, but if you follow them up for long enough, it gets up to around about 20%. That's with a 20-year follow-up, and the protective function that meniscus has done for the articular cartilage makes it worthwhile, I think. Lateral repairs seem to perform better than medial repairs, but trimming the meniscus in the lateral side is more prone to reoperation in the medial. And definitely, the outcomes in the long term, if successful, are better for meniscal repair than from trimming. In terms of arthritis risk, with a 9-year follow-up radiographically, 20% if you trim it, if you repair it, versus 60% if you trim it out. And then the outcomes of medial repairs are less than those of lateral repairs. So you need to be able to be a bit ambidextrous and switch balls and things to get the sutures in. But it's really important to think about the technique. And you need to make sure that you carry out abrasion both to the tear to remove the scar tissue and also to the synovium. And it may be from some work that's being done here in Leeds at the moment, but it's the synovial abrasion is where the stem cells come from that actually go on to form the repair's stability. And if we think of the tear in the same way as we would a non-union, you'd never stick a nail down a non-union without taking out the scar tissue that's formed there. So it's a really important part of whichever technique you're going to use. The gold standard remains an inside-out technique. And the success rates quoted by Noyes and his group are really impressive, and he studied it in great detail. And I did do inside-out repairs, and I'll still do those occasionally, but it is a bit of a faff, and you need to know the anatomy there to be able to get the needles back out safely. In terms of augmentation, you could use a fibrin clot, you could use the fibrin glue that we just heard about, form vascular canals, which is basically sticking a needle in it, trephonation. Microfracture picks can be used, so if I do a meniscal repair in a knee that doesn't have an ACL tear, then I'll stick the microfracture along the line of the notch to get some bleeding, hopefully as another source of stem cells to improve it. Porcine collagen membranes have been used, and these beautiful little cells here are the first stem cells that I got in a study that we're doing where we're looking at hemarthrosis fluid, which is a very rich source of stem cells. But there are disadvantages of the inside-out technique. You've got to do that incision, it's prone to infection, it takes longer, and you need an assistant, whereas you don't if you're using fast fix. And these needles are pretty whippy and difficult, and the patients don't like having a wound there, it can be painful. So what about other patterns of tear? Radial tears should be repaired, and historically we were taught that they would never work, but 3/4 of the time they can. And it will improve their function, and it will certainly protect them in the long term. But if you're in a hospital that doesn't have fast fix on the shelf, then they've all got white needles and 2-0 Crowley, and you can use these kind of outside-in techniques to achieve the same goal. A bit more fiddly, might take a little while longer, but it's worth spending time to actually reduce the risk of the patient going to have arthritis in the long term. There are techniques using newer implants where you can get a stronger repair, and I'll show you one of those later. What about horizontal tears? In the first place, should we bother doing anything to them at all? But we should do, because they do have consequences biomechanically for the knee. But there have been some studies where they've looked at whether it made any difference at all to the patient to take out that horizontal tear, and it may not. But we've all seen patients that have persistent symptoms that aren't settling down. And so repairing horizontal tears is possible, and it's successful again almost 80% of the time, and it's worthwhile in younger patients, I think. Trim away the central third because it's not got any blood supply, but if you can save 2/3 of the meniscus, you will reduce the rate of arthritic change in the long term. So root tears, I work in a trauma centre, so the most frequent sort of time I see a root tear is associated with quite a big wound. And there's a number of different techniques used there. The keyhole surgery that I'm doing here makes it quite easy really to get the access. There are arthroscopic techniques and new jigs available to help, particularly with posterior horn tears. Strobel described the ramp lesion recently, and that's something where really you're pulling the capsule back onto the meniscus, and that's been shown to improve stability when you find it. There are complications. Patient may need to come back to theatre. The failure rate is significant, it doesn't need to be mentioned, I think, in consenting. They may be a little more prone to stiffness. And if you're doing the inside-out technique, then you've got to be careful in your anatomy to be able to stop neurovascular damage. Rapid chondrolysis can happen whether you take the meniscus out or not. It's very rare, I've only seen it 6 times, but it's something that has been reported in the literature to be a problem associated with repair. And they will go on to get arthritis, but much later than if you just chop it out. And then the usual stuff, including death at the end. We've been told now we've got to mention death to our patients, 6 in 188,000. I wish the judges would stick to putting people in prison and leave us to look after our patients the way we want to. So post-op rehabilitation, personally I do limit my patients, I don't use a brace, that's my rehab protocol. And that could put somebody who's a carpenter or a roofer out of work. So you need to counsel a patient if you think they've got a repairable tear. So what about the future for meniscal repair? There's a lot of studies now looking at repairing tears that at the moment we'd all chop out. And travelled through to see Thomas Piontek in Poland, who's doing a study with Roller Jakob using a porcine collagen membrane meniscal wrapping technique. I didn't employ it in my clinical practice, but he's been able to show that very degenerate tears could heal on an MRI with a short follow-up. And stem cell augmentation may well be useful, fibrin glue may be useful, but at the end of the day, if you've got a tear that's repairable, then you should repair it. So I'll just show you a quick case. This is from Tuesday, hot off the press. 24-year-old Olympic gymnast. She'd been participating in the British Championships, landed a somersault badly, it was a back somersault with a full twist, and immediate swelling. She had a partial tear of her ACL, and this is the mechanism of injury. Fairly painful, and the gymnasts are hard. So she turned up, and we've got this tear at the anterior horn from the hyperextension that happened at the time of landing that fall. And can we have a show of hands? Who's going to repair this? Good. Who isn't? And the rest of you are asleep. Who's going to chop that out? She's 24. Well, I chopped it out to the white zone, and I didn't think that was something that was in her interest. So there we go. That one's going, and that's it after the resection. But further back in the knee, there's a little bit of chondral damage associated with that tear, but further back in the knee, there was an unstable tear that's moving more than 3 millimeters, that's over 2 centimeters squared. And to reinforce the point, this is a proper diamond rasp. Smith & Nephew give you something that looks like a sort of mace now, very cheap, no diamonds. But this is about 20 years old, and it actually does the business. And you can see the scar tissue there, where I've freshened up the tear. And then for me, I prefer the old-fashioned Fast Fix Ultra. 360 is a bit too stiff for me. Pop that in, stitched it, now it's stable. So shaving quickly may get you the job as the president of the US of A, which it did for Ronald Reagan. So that was the TV advert that launched his career in the media. But shave out as few tears as you can. And it's much better to leave shaving for what's on your chin, really, not in the knee. So moving on now, the surgical approach in articular cartilage repair can have an effect on cell viability. So I'll just give you a quick run through what the historical approaches to articular cartilage resurfacing is, and then come right up to the Daily Mail last weekend. So Priddy, after he died actually, posthumously had published his series of patients with this huge approach, turned down at the patella, massive drilling, for patients with fairly end-stage arthritic problems, and he quoted around about a 75%, I think, success rate, 77% success rate in terms of pain relief, and they did well, but they weren't quite as happy about their functional outcomes, but that's from the 50s, he did really well. Chondrocyte implantation has been around for 30 years. The ICRS had a celebration over in Gothenburg earlier this year for the 30th anniversary, and it works well. It's been around for a long time. We know there are some risks associated with the first generation techniques where periosteal patches had to be used, but even with those first generation techniques, there's a success rate of over 70% in terms of chronic relief of pain and improved function. So MACI is a technique that I've used the most, and of all of these cartilage techniques, there's that arthroscopic part at the start where you're going to get your biopsy. And then I don't know if anybody here took part in the active trial. Its early results were quite difficult to comprehend. Microfractures seem to be performing the same as the cell-based technologies, but for NICE's recent decision, they were informed of what's going to be published next, and actually it does drop off, as Ian mentioned earlier on. So cell-based techniques are better than microfracture in the long term. So this was my first case. There's 12 million cells in that syringe, £18,000, fantastic. And what wasn't fantastic was having to harvest the periosteal patch, and it was difficult to get, variable quality, bigger incision. And the historical problems of periosteal patches came along to haunt me as well. The fluffy cloud there is the periosteal hypertrophy, so then you've got to go back in and shave that off. But having done that, it doesn't really affect the long-term outcome. So it's a bit of a pain, but it's there and you can use it. So if you've got somebody who's got a big cartilage defect and you don't have any of this porcine collagen bound, you can still use periosteal patches. I've had to do recently myself. So I was fortunate enough to be filmed for the Isocos Congress down in Japan some years ago, And this isn't our operating theatre in Liverpool. We don't have chandeliers. We don't have an assistant usually. But MACI is a very good technique you can use in porcine collagen membrane. And so that improvement in the technique had several advantages. The incision is smaller, the surgery is quicker, the patch is reproducible. And they started off stitching that on and then injecting under it. And after that then realised actually you could wick the cells into it, which is what MACI became, and then just simply glue the patch on, which works for tibiofemoral lesions, but not, personally I wouldn't do that on a patella, I would still stitch the patella. The Summit trial was a really good trial, multi-centre study. Daniel Saris in Utrecht ran it, massive numbers, 16 sites enrolled across 7 different countries, and this is the type of procedure, the MACI implant, which you're probably all familiar with. After 12 hours, the cells are moving off that porcine collagen membrane. It's like a postage stamp. By 36 hours, they're sitting on top of the fibrin glue, and in 2 weeks, they're in the fibrin glue, and the glue starting to disappear. So it's a delivery system. And the Summit trial, another one of these kind of the names made up from a very long title. God knows how they got Summit out of that. But it was comparing microfracture to MACI. And it's the biggest prospective randomized trial done with good clinical practice technique in the literature. And it definitely showed that by 2 years, treatment response was significantly better in the cell-based treatments than in microfracture. Very well performed trial. So there is a natural progression for us to try and do things for our patients that are less painful through smaller holes. And Priddy's drilling technique has been really sort of turned into Stedman's microfracture. It's an arthroscopic technique. And so why not try MACI arthroscopically? The first case report for this was in 2004. A bunch of guys in Italy. They had a patient with a tibial plateau lesion, and the amount of damage that you'd have to cause to be able to do an open technique was such that they thought about it, tried it arthroscopically, and it worked. The first case series was published slightly after that in 2009, and the first documented written technique of how to carry out MACI in an arthroscopic fashion was published by a group including guys from Spain, Stephen Allen. But it's quite a complicated technique, so a bunch of us got together, sponsored by Genzyme, who between a lot of us had about 390 articular cartilage resurfacings between us, and we published the technique for the arthroscopic delivery of the MACI implant. And this is the procedure. So keyhole surgery, the first stage is exactly the same as it is for any cartilage surgery. You've got to figure out the size of the defect, use a template of whatever type. By the time you've done a few, you can kind of guess at it, and it generally is easy enough to do that. And then passing the implant in with as gently as possible through a portal, and then you don't have to make a hole big enough to get your thumb on it to hold it in place. You can use a bladder syringe, inflate with saline, and that'll press the graft up onto the base with the tie seal we were using. Obviously, there are other glues available. And that has good long-term outcomes. So Greg James, who's got the biggest series of these, published on his 5-year outcomes, and he found that the patients were doing well. They'd had 2 out of something around about 35 had needed revision within 5 years, and they were happy patients. But it's not going to work for everybody. This patient had a massive lesion of the medial femoral condyle going through into the trochlea, and arthroscopic surgery is never going to work for that. So between Professor Beyond, who's down in Manchester now, and myself, we carried out a study up in the Royal College of Surgeons in Edinburgh to compare the traditional open technique through a small arthrotomy with arthroscopic surgery. Because Hindle and his colleagues suggested that messing around with these implants isn't a good idea, and the cells are quite tender little things, really. So for me, the open approach is easier. There's less handling of the implant, and it makes it easier to debride. But the arthroscopic approach has been shown to have a quicker rehabilitation. There's less pain and suffering for the patients, and so why not do it? The drying that's associated with an arthrotomy may be an issue as well. So we wanted to have a look at the arthroscopic versus open technique and see how many cells were there and how many were alive. So we had 8 young cadaveric knees. They were all under 51 years of age. We created defects on the medial and lateral femoral condyle, and Professor Bion had the easy job. She did 8 open procedures, and I did 8 arthroscopic procedures in an afternoon. We didn't use fibrin glue because we needed to retrieve the implant after it had been positioned. We retrieved the implants, and then we used various techniques for seeing whether the cells were there on the implant and whether they were alive, and we had a look at them. So the results, the main result was that after 8 arthroscopic Macy's, I was knackered and needed to have a little sleep. But the duration of surgery, even though I've done a few of them, was significantly longer. And so the open technique's a very quick, reproducible technique. And unfortunately, the number of cells that were there were far higher on the open technique too. And it gets worse. The cell viability, green is good, red is bad, okay? So when the implant turns up, 97% of the cells are alive, staying in green. Even after the mini-arthrotomy technique, only 37% of them are alive. And unfortunately for me, having spent a lot of time developing this arthroscopic technique, only 3% of the cells are seen to be viable. So that handling is significant. So in conclusion from that study, mini-open surgery, I think, is probably the way ahead for the Macy technique anyway, because you've got significantly more cells there, more of them are alive, and it's quicker surgery, which is okay, it's good for the patients. Although Greg James' outcomes are good, and we don't really know how many cells you're supposed to have in there. So as the Fun Boy 3 and Bananarama said in the 80s, it ain't what you do, it's the way that you do it, okay? And we need to know what gets results. So I'd ask any of you that are doing any articular cartilage work to participate in the ICRS registry. I'm on the steering committee of it. The patients do all the work in this. There's a very short section there you fill in what you've done to the patient, and then they'll be followed up. So we, between Tim Spaulding, myself, Professor Bion, and unfortunately he's not with us any longer, Andrew Sprouson, we managed to get 104 of us, and most of you in the room may well have participated in this. 104 orthopaedic surgeons agreed on something. Wow. We got it published in the knee, and that's been used quite a lot in NICE's recent decision to stop faffing about. They're not procrastinating anymore, and they've accepted that autologous chondrocyte implantation should be used for treating symptomatic cartilage lesions in the knee. And even better, they've identified the fact that you shouldn't mess around with microfracture in a lesion that's over 2 square centimetres, because there's a 6-fold increase in the failure rate of a subsequent Macy. And so I think medical legally now, you're going to have to be careful, because NICE has put this guidance out. If there is a lesion that's greater than 2 square centimetres, NICE guidelines say that that should be treated with a Macy, with some cell-based technique. And there's a lot of hassle involved in this, an HTA license, it's time, it's money, so it'll probably be something that's done in tertiary referral centres. The biggest, after the biggest source of patient information is the Daily Mail, isn't it? And even bigger than that, the Sunday Mail. So this article was published, I think, last weekend, and they've got the wrong end of the stick really, because we're not cloning anything, and we're not doing sort of grow your own knee replacements, and it's not a treatment for arthritis. However, the diagram that's on that website is quite useful, so if you're doing this, it's a nice picture, and it helps to explain to the patients what's involved. So thank you very much for your attention. If you want to know anything about the rehab or any of the techniques, then I've got patient information on the website, and thanks very much for staying awake.